It is best to gather all required supplies prior to starting the neonatal neurological examination. We suggest the following: an ophthalmoscope, a pen light, cotton balls and peppermint oil, or mother's breast milk if peppermint is unavailable, a reflex hammer, sucrose and a soother, a glove, cotton-tipped swabs, a measuring tape, and hand sanitizer. An environmental scan should be conducted prior to the beginning of the examination. Attention should be paid to the infant's vital signs, any medications, particularly infusions, and the infant's measurements should also be obtained if not recently completed, including the infant's weight, length, and head circumference. For the purpose of the video, the weight and length are not demonstrated. To measure the head accurately, the tape should be placed along the occiput and then brought around the head above the level of the ears and atop the eyebrows. After measuring the head, the infant's fontanelles, including the posterior and anterior fontanelles, should be palpated, along with the suture lines. The formal neonatal neurological examination should begin with an assessment of the level of alertness. The level of alertness, often referred to as the infant state, will vary depending on time of last feeding, environmental stimuli, recent experiences, and gestational age. The infant should wake, their eyes should be open, and the infant should appear bright.
Oh, there, yeah.
Olfaction is rarely assessed in the newborn period. If assessment is required, a peppermint ball soaked with peppermint extract can be used. Normal infants greater than 32 weeks gestation should respond with sucking, arousal withdrawal, or both.
Is it just me, or he's not doing
He's
it?
not doing it. Hey, buddy. Can you wake up a little bit?
He's camera shy.
Hello. 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 So you needed a fix on the red ball next, mister. So you need to be awake.
By term, visual fixation and following are well developed. For testing of visual fixation and following, a fluffy ball of red yarn can be used. If yarn is not available, another red object can be substituted, or alternatively, an infant should fix on the examiner's face when the infant is held at an appropriate distance away. This distance should be approximately an arm's length to simulate the distance between the infant when at the mother's breast and his mother's face. Fundoscopic assessment in the newborn period can be challenging and often requires two individuals. One to assist in holding the neonate's eyelids open, as demonstrated here.
Okay, do it.
Attention should be paid to the red reflex, assessment of the vessels, and visualization of the optic disc, if possible. This should be repeated in both eyes. Pupils are most easily assessed in the quietly awake infant, but can be challenging to assess because their eyes are often closed and they resist forced opening. Comfort measures, such as a soother or bundling, can be helpful in keeping the patient calm. If the infant is very active, it is helpful to have another person keep the head still. The ambient lighting in the room should be consistent, as bright light on one side of the patient, such as from an open window, can cause the pupils to look falsely asymmetric. When assessing the infant's pupils, first note whether the infant flinches to light. This response will become diminished with repeated introduction of the light during a single assessment. Then note the infant's initial pupil size and shape. The pupil size will vary depending on the infant's gestational age. When the light is introduced, the pupils should briskly constrict. While many medications can affect pupil size, constriction of the pupil with introduction of light should be maintained. When assessing the infant's extraocular movements, it is important to note the infant's eye position, spontaneous eye movements, as well as movements elicited by the doll's eyes maneuver. In most premature and some full-term infants, the eyes are slightly disconjugate at rest. This can be easily appreciated by observing how the light is reflected off each pupil when the light source is held at midline, approximately 2 feet away from the face.
Any words of wisdom?
There's only one thing you can do, promise them a pony.
Pony for a boy.
Yeah, you're right. That was stupid.
It's like a video game or something.
71 Chevelle.
Yeah. You good. You good. Now slowly take it out.
Are you filming? Option is rarely assessed in the newborn period. If assessment is required, a cotton balls and peppermint extract can be used. Normal infants greater than 32 weeks gestation should respond with sucking, arousal withdrawal, or both. Yeah. Okay. So next is going to be vision. Do I use the ball or your face or both?
Facial sensation can be examined with a pinprick. The infant should grimace, starting with the side of the face that has been stimulated.
There we go.
Masticatory power can be assessed by evaluation of the infant's suck when assessed with a gloved finger. It is important to assess the infant's face for symmetry at rest and with movement, paying attention to the onset of movement as well as the amplitude of movement, compared from one side to the other. Particular attention should be paid to the palpebral fissure, the nasolabial fold, and the position of the corners of the mouth. Observing an infant's response to noise provides assessment of gross hearing. By 28 weeks gestation, the infant will startle or blink to a sudden, loud noise. As the infant matures, you may notice more subtle responses, such as cessation of motor activity, opening of the mouth, and wide opening of the eyes. Assessment of the infant's suck, swallow, and tongue function is important, as these must all function together in a coordinated fashion. It is best assessed with a gloved finger. The gag reflex can also be assessed along with the suck, either by advancing the gloved finger or with a small tongue blade or cotton-tipped swab. Tongue function, as we have discussed, is best assessed during the act of sucking on the examiner's gloved finger.
If it's just
Assessment of cranial nerve 11, the accessory nerve, can be difficult, as the function is to flex and rotate the head in the opposite side. Passive rotation of the head reveals the configuration and bulk of the muscle, and function sometimes can be estimated if the infant attempts to flex the head. Taste is not routinely assessed as part of the neonatal neurological examination. If necessary to test, use of a sweet substance can encourage interest in the infant. It has been demonstrated that infants will suck in longer bursts, have fewer rest periods, and an increased heart rate when presented with a sweet fluid, such as 14% sucrose. Normal newborn posture is best observed in a calm infant and is an important part of the neurological examination. By term, the infant assumes a flexed posture of all limbs. Fisting, usually bilateral, is the predominant hand posture. To assess peripheral tone in the upper extremities, the scarf sign can be utilized. In the lower extremities, the popliteal angle and heel to ear are commonly used. Positioning is important when assessing tone, as the infant's head should be midline, and attention should be paid to symmetry from side to side.
When assessing the infant's mobility and power,
When assessing the infant's mobility and power, it is important to consider the quantity, quality, and symmetry of motility, as well as the muscle power. In the first 8 weeks following delivery of a term infant, movements predominantly present with a writhing quality. There are 3 core maneuvers typically used to assess central or axial tone. These include head lag, vertical suspension, and ventral suspension, all demonstrated here. Tendon reflexes that are readily elicited in the newborn include the pectoralis, biceps, brachioradialis, knee, adductor, and ankle jerks. There are various reflex hammers available for use, but demonstrated here is the Queen's Square. The reflexes are easily elicited by tapping the examiner's finger placed over the tendon of the designated muscle. An exception is the ankle jerk, which is easily elicited by tapping the finger placed over the distal plantar surface of the foot, as this stretches the Achilles tendon and elicits the reflex. Ankle clonus of 5 to 10 beats also should be accepted as a normal finding in the newborn infant if no other abnormal neurological signs are present and the clonus is not distinctly asymmetrical. The plantar response is usually stated to be extensor in the newborn infant and can be elicited by dragging the thumbnail along the lateral aspect of the sole. There are competing reflexes, as described in the text. Thus, evaluation of the plantar response must be taken in consideration of these. The Moro reflex, elicited best by the sudden dropping of the baby's head in relation to the trunk, should consist of opening of the hands, extension and abduction of the upper extremities, followed by anterior flexion of the upper extremities, and an audible cry.
Are you too sleepy?
Palmar grasp can be elicited by gentle pressure to the palm of the infant's hand. This should be strong enough and associated with enough extension of the upper extremity muscles to allow the term infant to be lifted from the bed. Similarly, the plantar grasp can be elicited by gentle pressure to the middle of the infant's sole of their foot. The tonic neck response, elicited by rotation of the head, consists of extension of the upper extremity on the side to which the face is rotated, and flexion of the upper extremity on the side of the occiput. This is typically less striking in the lower extremities. This is often referred to as the fencing position. Evaluation of sensory function is frequently imprecise and relies on observing withdrawal as the infant's response. The rooting reflex, elicited by tactile stimulation of the perioral region, does assess for sensation of the face. To assess responses of the infant in the extremities, pinpricks can be utilized. Observe for latency, limb movement, facial movement such as a grimace, vocalization as a cry, and habituation.